Good afternoon. It's really an honor to be here this afternoon. I'm losing my voice a little bit, so I apologize in advance if I sound like Minnie Mouse. We've talked a lot today about the challenges associated with translating new technologies from the lab into clinical practice. But sadly, our efforts to translate these technologies often do not extend beyond the borders of the developing world. Who pays the price for these failures? 4 summers ago, I met these 3 little girls outside St. Gabriel's Hospital in Namatete, Malawi. I love this picture. These little girls are so beautiful and so funny, but the health challenges that they face are enormous. Every year, 8 million children under the age of 5 die. 98% of the children who die live in the developing world. We lose little girls like these, and they could be saved with technologies that are readily available in the developed world. This photo shows a primary care lab in the developing world, and there are only 2 pieces of equipment in this lab. There's a microscope, which is next to the window because there's no electricity, and so the sunlight serves as a light source. And there's a hand crank centrifuge. Clearly, innovation could transform healthcare in this setting, but the technology needs of this clinic are largely invisible to technology developers. And in some ways, this isn't surprising. Who would pay for these technologies? How would we get them there? There's no infrastructure to support them. There's no supply chain to deliver them. And if they break, there's no one to repair them. If we truly believe that healthcare innovation should be available to all the world's citizens, we have to think about innovation in a different way. And today I'd like to share 3 examples of how we might do this. This photo shows the neonatal nursery at the largest teaching hospital in Malawi. At times, often, as many as 4 babies have to share one bed. In Malawi, 18% of babies are born too soon, the highest rate of preterm birth in the world. Over half of all premature babies struggle to breathe because their lungs are immature. In Malawi, as you see here, the only therapy available to treat babies with breathing difficulties is nasal oxygen. In the 1950s, this is the therapy that was available for babies with respiratory distress in the United States. And we know from historical data that with nasal oxygen alone, only 1 of those 4 babies will survive. Since the 1970s, however, we've been easily able to treat respiratory distress using a technology called bubble CPAP. And in the United States, the introduction of bubble CPAP raised the survival rate for babies like this from 25% to 75%. But at $6,000, bubble CPAP machines are simply too expensive for most developing world hospitals. With clinicians from the United States and Malawi, we tasked a team of engineering students with designing a bubble CPAP device for the developing world. In a year-long capstone design course, this team of students engineered a $160 device that delivered the same therapeutic flow and pressure as the systems routinely used in the developed world. With clinicians from the US and Malawi, we tested the efficacy of this device. Just like in the United States, what we found was that the survival for these babies rose from a baseline of 24% to 70%. With support now from USAID, the Ministry of Health in Malawi, and a commercial partner, we are now implementing this technology at all government hospitals in Malawi. This photo shows Jocelyn Brown, one of the students that designed the original CPAP device. And since graduation, she's been working in Malawi to disseminate this technology. Last month, she helped introduce CPAP at Machinga District Hospital. Afterwards, one of the nurses came up to her and revealed that her baby was one of the babies in the initial CPAP trial. Her daughter was born prematurely, and as you can see here now, 6 months later, she's doing very well. With students like Jocelyn, we're working to develop the nursery of the future for district hospitals in the developing world. a comprehensive set of highly effective, affordable technologies to help newborns survive and thrive. We estimate that a nursery of the future for a district hospital serving 300,000 people could be outfitted for only $5,000, less than the cost of one Western-style ventilator. Like many developing countries, Malawi is also facing a growing burden of chronic disease like cancer. Cervical cancer is the leading cause of death for women in sub-Saharan Africa. A year ago, I asked Alex at St. Gabriel's Hospital to tell me about the challenges that he and his team of community healthcare workers face in dealing with cervical cancer. He reached into his desk and he pulled out a bottle of morphine. And he explained that his team cares for many homebound women who are dying from cervical cancer. To help manage pain, workers leave behind bottles of liquid morphine, and they instruct family members to pour the correct dosage of morphine round the clock. And he asked our team to help develop a better dosing system to manage pain relief and allow women to die with dignity. And we helped him with that. I don't have time to tell you about it. But what I want to focus here on is the fact that we should not be thinking about palliation because we know how to prevent cervical cancer. We know with early detection and with vaccination, we can prevent cervical cancer. And we know exactly who to target. Women who are HIV positive are at particular risk of developing cervical cancer. This is an HIV clinic in Swaziland, and there's a poster on the back of the wall that counsels HIV positive women to get screened for cervical cancer. So I asked a nurse at this clinic how many pap smears they had performed in the last year, and the answer was 0, because they simply did not have the infrastructure or the supplies to implement screening programs that have been so successful in the developed world. As part of the Red Ribbon, Pink Ribbon campaign, nurses are now using a technique called visual inspection to identify precancerous lesions of the cervix. The problem with visual inspection is that only about half of the lesions that they identify actually require treatment. They have to treat everyone, and so precious resources are wasted. Now, while the infrastructure for screening is absent in the developing world, cell phones are everywhere. Taking note of this, our team developed a cell phone microscope that could be used to improve the identification of these precancerous lesions. This slide shows photos of the cervix from 2 women, and both have lesions that would trigger treatment, but only one actually requires treatment. Here you can see the fiber optic probe on those cervical lesions, and it allows the providers to visualize the nuclei within those cells, and you can easily tell that the nuclei are enlarged and crowded on the bottom. That's the woman who requires treatment, whereas they're not on the top. Studies in China and Botswana using this technology have shown that we can reduce by half the amount of overtreatment using this very simple technology. And more importantly, we can leverage decades of investment by the consumer electronics industry to create the diagnostic lab of the future, where we can create palm-sized battery-powered readers that can be made for less than $10. They can be coupled with microfluidic devices to enable sensitive testing for nucleic acids, proteins, and metabolites at the point of care, reducing per-test cost by as much as 2 orders of magnitude. Today, there is a groundswell of student activism to change the future of global health. How can we ensure that the next generation of engineers is fully engaged in this effort? Recently, I came across an old book that I think holds part of the answer. The Boy Engineer was published 50 years ago in an effort to recruit more young people to the field of engineering. And in the first chapter, the author writes, "The nations of the free world are engaged in fierce and real competition with nations ruled by dictators. The winners in this competition will be those governments which, while maintaining peace, supply their peoples with the highest standard of living. And in this age of technology, engineers are behind a large proportion of the advances in the standard of living." In the midst of the Cold War, expanding the pipeline of future engineers, at least boy engineers, was an important priority. It was critical both to national security and economic competitiveness. Today, I think we have an opportunity to embrace a new kind of international engagement for engineers, which I think is important both for humanitarian as well as national security reasons. Engineering students are so excited about the technical challenges associated with improving health in the developing world. And these students recognize the importance of working with their peers throughout the world to design technologies that can be used at teaching hospitals in Malawi and at rural clinics in Swaziland. But the need to build engineering capacity in Africa remains great. The number of engineers emigrating from South Africa, it's been estimated, is equivalent to the number who are graduating annually. Yet African governments are starting to invest in this area. Ethiopia just started its first biomedical engineering undergraduate program. And at Tegbarid University, the biomedical technician training program is engaging their students in the design of appropriate technologies. And these efforts provide very interesting opportunities for partnership. So in closing, I challenge you, all of you, to think about how you can make addressing these very important challenges at least a small part of your professional efforts. Because I think if, as engineers, we can reach beyond the boundaries of our discipline and partner with NGOs and industry and policymaking groups, the resulting technologies will have global benefit. Thank you.